I'm Robert Schertzer, Clinical Associate Professor, UBC Ophthalmology and Visual Sciences, and we're talking about glaucoma for January 15th, 2010, with Karim Damji, Professor of Ophthalmology at the University of Alberta in Edmonton. Dr. Damji's main areas of research include pseudoexfoliation glaucoma, SLT, or Selective Laser Trabeculoplasty, versus medication as first-line therapy, and whether SLT reduces diurnal variation of intraocular pressure. Before joining the faculty at the University of Alberta, Dr. Damji spent a number of years on faculty at the University of Ottawa. Please check the show notes of this podcast for relevant research articles on laser trabeculoplasty. You will also find links in the show notes to follow me on Twitter, where I am Rob Schertzer, on my blog at wholelotofrob.com, where I cover glaucoma health and technology, and to my glaucoma website at westcoastglaucoma.com. Let's welcome Karim Damji to our show and talk about selective laser trabeculoplasty and where it fits into our treatment algorithm for open-angle glaucoma. Well, welcome to this episode of Talking About Glaucoma, and this week I'm talking with Karim Damji. Hi, Karim.
Hi, Rob. Thanks very much for asking me to come on. It's a pleasure.
Why don't you tell me a bit about yourself here?
Okay, I'm a professor of ophthalmology at the University of Alberta, and I do some research and teaching as well, so I really enjoy those opportunities to share what I learn.
That's great, and now hopefully we'll share a few pearls about laser trabeculoplasty, which I think a lot of people know has been something you've published a fair amount on. So let's just start, I guess, with a bit of a background about the study that was originally done, and we'll see where the talk leads us.
Great. The study actually was planned over 10 years ago, and as a randomized trial comparing SLT to Argon Laser Trabeculoplasty. And I thought at the time, in 1998, that it was important to do a comparison because it wasn't just enough to have a laser and prove in one arm, that things were working. And you needed a comparison, not just for efficacy, but also for safety.
I'd say 10 years ago, I probably wasn't doing a lot of trabeculoplasty because I was getting the feeling it really wasn't working all that well. And my feeling since that time has been that it's probably related to where it was in our sort of staged approach to treating glaucoma.
Yes. That's a very interesting point that you raise. First of all, I think it is a historic time to be talking about laser trabeculoplasty. Jim Wise and Witter published their paper on ALT 30 years ago this year, and Mark Latina had published his paper on SLT just over 10 years ago. Our study really looked at placing those laser trabeculoplasty treatments as part of a stepped regimen where we tried to maximize medical therapy first, and patients on average with primary open-angle glaucoma, including pseudoexfoliation, some pigmentary glaucoma, had about 3 meds, and for most people that was sort of the maximum tolerable medication, and they were still uncontrolled. And most of the patients were sort of early or moderate stage glaucoma and needed to go on to something more to control their pressure, which traditionally would have been a trabeculectomy had we not considered laser trabeculoplasty. So we randomized those patients, and in our study we were able to show that pressure came down from a baseline of about 24 millimeters of mercury in each group by about 20%, and in some cases as much as 25%. If you did it 180 degrees with either SLT or ALT, there was essentially no difference in outcome with regard to pressure or, in fact, complications. But I think to go to your point, if you were to do it earlier and the patient is not on as much medication, so either right off the bat or with one medication, you tend to see a little more effect. And, of course, these days people are doing 360 degrees of SLT quite often early on as well. In which case you can see 30% or more effect right off the bat.
That's right. So I guess what some people may find surprising today is the results of that initial study showing really no difference, right? It really helped show that SLT was as effective as ALT, that it wasn't really something better.
Exactly, equivalency. And I think, in my mind, it was important to show the equivalency. And even though SLT didn't turn out to be better in terms of efficacy and safety, I think the promise was that you could repeat it and that you were causing less in the way of architectural damage to the trabecular meshwork because you weren't creating that thermal effect. And instead it was quite selective for certain cells with pigment. So that would mean in a couple of implications. One is that you could possibly repeat it and continue to have effect instead of creating glaucoma, which, with ALT, when you continue to repeat it, you can actually create a nice monkey model of glaucoma. With SLT, that's much more difficult to do. And the second thing was really that you're not damaging the architecture that much. So if there are new surgeries that come on the horizon, and in the last 10 years we've seen some, such as trabectome, which is an ab internal trabeculectomy, or canaloplasty and so forth, viscocanaliculostomy and so on, that basically you haven't damaged the architecture in such a way that those procedures become very difficult. And anecdotally, surgeons are noticing that those patients treated with SLT are generally not a problem with these newer surgeries, whereas those with ALT, you tend to have more scar tissue, and technically it's more difficult to treat.
That's right, and I remember the first few years after you had done the study and you would present the data to different forums, I'd say every single time you must have been asked, have you shown the repeatability yet?
Exactly.
Now, since that time, how do we have data to show the repeatability rather than just the theory that you're causing less damage with the SLT?
Right. It's shocking to me that there isn't more published on SLT. I think people just got on the bandwagon and forgot to do the studies, because the only paper really that I've seen come out looking at retreatment is one by Bruce Shields and his group. The first author is Hong, H-O-N-G, and it's in the Journal of Glaucoma earlier this year, March 2009. And essentially what they showed was that you could treat 360 degrees and then repeat treatment with another 360 degrees. And instead of getting 20% reduction, you get less, about a 12 to 15% reduction, but you still get some effect. And it's a retrospective study. So I wish that ICOMED and some others with a larger data collection would publish on this, because our study was never really designed to look at repeatability. And so I'd love to see more data on that. But I think with repeat treatment, it is possible to get reductions, but not as large. Anecdotally is my experience as well.
Right. And it's very interesting, those percentages that were given with the repeat treatment being less effective than the initial treatment. It goes back to what I said, alluded to earlier, where we've sort of been moving the trabeculoplasty earlier into the treatment regimen, sort of as a substitute for adding a drop. Mm-hmm. And it seems to be similar numbers to what we get when we have a first drop that we put a patient on, and then when we add a second drop, the fact that we get less of a pressure reduction with the additional drop.
That's right. In our study, the only prognostic indicator for a result was the baseline IOP. In other words, the higher the baseline IOP, the more drop you got. And others have shown that since then as well. Degree of trabecular meshwork pigmentation, type of glaucoma, and so on didn't seem to matter that much with SLT. And I think that's part of the reason we're seeing more effect when SLT is done earlier. Typically the baselines are higher. So, for example, in the study by Hong, when the second SLT was done, the baseline was actually a bit lower.
Right.
That may be part of the explanation.
Oh, so by having the lower initial treatment, initial pressure when initiating the treatment. So now in terms of, let's say, the practical take-home points from this, where do you place SLT now in the treatment regimen?
I think for me there's a number of spots. First of all, I think quality of life is the key consideration when you're looking broadly, right, in terms of glaucoma therapy. And I think setting a target pressure range is important. There's enough evidence to show that pressure lowering is the key strategy, really. And So I think it depends how much pressure lowering you're looking for and what would be best for that particular patient, given various, if I can use the term, biopsychosocio-cultural considerations. And so in other words...
You can. I don't know if anyone else could use that term, but you can go right ahead.
Yeah. In other words, a little more holistic approach. So
right.
I don't jump to medication right away. I talk to the patient typically if they're a newly diagnosed glaucoma or a glaucoma suspect that's high risk, and we do want to treat and lower the pressure, then, I often discuss with them different options, and typically medication, laser, and occasionally surgery if the patient can't afford or medication or is forgetful, etc. And and after a discussion, usually patients opt for, a prostaglandin analog once a day at night or SLT. And if I'm doing it early in the treatment regimen, I typically do 360 degrees because the studies by Madhu Nagar from the UK and our own study working with Jay Katz as part of a multi-center study, SLT meds that was actually presented at the Academy one year, showed that you get about a 30% pressure lowering with either 360 SLT or Xalatan in the case of both those studies. And so I feel pretty comfortable offering it early on if people wanted to go for that. I think most people do opt for medication and then go for laser more as a second or third step. And in the second or third step, I try and position it in such a way that here we're looking at possibility for 20-25% pressure lowering, much like an additional drop. But then you don't have the additional concerns or compliance-related issues. Once you start adding more than 2-3 drops, the chances of the patient actually taking it the way you hope drops off, right? And compliance is a major issue. So I think there it has a good potential. And it also has a potential, based on a study by Francis and others, that you can actually cut back the medication that a patient is taking. So if somebody's on 3 medications and they want to cut back to 1 or 2, then that's another good, benefit. So to summarize, really, I offer it to newly diagnosed patients as initial therapy, but certainly talk about medications, surgery if appropriate, and then my mainstay, I would say, and again, my practice is biased towards tertiary glaucoma care, is usually as part of a second or third step prior to going to actual incisional surgery. And then occasionally in steroid responders, I use it as well. It tends to work quite well in that group, just to buy a bit of time.
Yeah. Well, I wish I could disagree with you just to have an argument, but you really summed up my approach as well. I guess the only thing I might add, though, is it's when I go through the whole holistic approach and discuss things with the patient, it's amazing that some patients don't want an eye drop anywhere near their eye, and others don't want a laser anywhere near their eye, and you don't always know what they're going to opt for, but it's definitely important that they're actively involved in deciding that.
Yep, and then the other big thing, of course, is we have an aging demographic, and some people have memory issues and so forth, so there's often a care partner, a caregiver involved, and so it's important to have the discussion with them, whether it's family or otherwise. And so often, I'm speaking to other family members, and we actually have a nurse educator do some teaching sessions, much like Pierre Blondeau's model, outside of the formal clinic setting to help educate patients and caregivers as well.
Right, that's excellent. Wow. Well, I think we've covered the subject really well, unless there are any other things you'd like to add that we didn't cover here.
Well, I think we've covered most of the points. The only other thing is that I think in terms of contraindications, one needs to be careful in eyes where the meshwork is not easily visualized, patients with uveitis, and patients with long-standing pigmentary glaucoma, where I think the trabecular meshwork has very few cells left, and doing SLT, particularly high-powered SLT, can decompensate the meshwork. So I think with those caveats in mind, it's fair to at least try it in most patients where it may be helpful.
That's right. But, I guess whenever the angle is pigmented, that's a good point to. You mentioned lower energy settings in there, and
yes,
definitely.
So, I mean, typically with pigmentary glaucoma I'm dealing with, I would turn the energy way down to 0.4 millijoules, 0.5 with pseudoexfoliation, maybe around 0.6, 0.7. But For the most part, the average treatment energy should be about 1 millijoule per pulse, about 50 treatment spots for 180 degrees, and then anywhere from 80 to 100 spots for 360 degrees, I think, is fine. And then I would encourage people to check the pressure an hour later and to also pre-treat with an alpha-2 agent. If it isn't checked an hour later, then maybe the following day. But, you can expect about a 3%, 4% chance of a pressure spike above 6 millimeters of mercury. And I still am old-fashioned. I use Predfort QID for about 5 days afterwards. That's just a bias of my fellowship training. But
I guess we're both old-fashioned here. I do that for 3 days.
Yeah, but there's enough good evidence, of course, to, you can use a non-steroidal. In some cases, people don't use anything and get away with it as well. So I think those are the key things I would add.
Great. Well, nice having this conversation from one old guy to another.
Thanks a lot, Rob. It's a real pleasure.
Yeah, that's great. Well, that's our show for today. Be sure to subscribe to this series so that you will receive each episode as I produce them. Sometimes I get bogged down with my family commitments, clinical work, or carried away with my blog or Twitter, but still greatly enjoy producing Talking About Glaucoma when time permits. Drop me a line at podcast@iguy.org, that's IGUY.org, with your feedback or suggestions for future episodes. You can also enter comments about any episode on the podcast pages on wholelotterob.com/tag-AAC. See the show notes for more details. Talking About Glaucoma is a non-profit podcast that I produce once each month or so, as time permits, in AAC format that includes chapter markers, and in MP3 format that does not. I am the director of the West Coast Glaucoma Center in Vancouver and clinical associate professor of ophthalmology and visual sciences at the University of British Columbia. I can be followed on Twitter, where I am Rob Schertzer. Also, check out my work website at westcoastglaucoma.com and my glaucoma health and tech blog at wholelotterob.com. Please help detect and treat glaucoma by keeping yourself informed. How was your surgery?
Well, thanks. Yeah, fine. It was acute on sort of chronic angle closure with some phacomorphic component. And the problem is she had a scleral buckle and multiple detachment surgeries, and so it wasn't much healthy conj. So I ended up doing cataract removal, ECP, and then synechialysis.
Oh, special number 3 from the menu.
There just wasn't room to do any trab or tube or anything.
Oh, God, nice.